in Europe, both Greece and Italy now. But the truly exciting news today is, of course, our presenter, Dr. Iliana Lega, who received her bachelor's degree in science from the University of Toronto in the year 2000, followed by an MD degree in medicine from the University of Western Ontario in 2004, internship and residency in internal medicine from McGill University in 2007, and then her first fellowship in endocrinology and metabolism, also from McGill in 2009, and then a second fellowship ongoing in women's health here at the University of Toronto in conjunction with a master's degree in clinical epidemiology through the University of Toronto. She's currently a clinical associate at Women's College Hospital. She holds a very prestigious fellowship award from the Canadian Breast Cancer Initiative, multiple prizes for academic excellence, and 3 first author Medline articles. So this is a stage 2 thesis proposal, which means the candidate gets to speak in an uninterrupted manner for about 20 minutes, followed by about 10 minutes of questioning, followed by everybody who is everybody leaving the room who is not at the level of assistant professor or above in any department in any university. So that if you're an assistant professor of astrology in Botswana, you still can stay and vote. All right? So that for a whole bunch of us, it's over in about 30 minutes. For Iliana, of course, it may take a lot longer. Okay, we're all yours.
Thank you. Thank you for the introduction, and thank you for coming. And this is my stage 2 proposal defense. The title of my proposal is The Impact of Metformin on Survival Following Breast Cancer. Briefly, I'll take you through a background of the topic, and then I'll get into the research question and the rationale, as well as leave time for questions. So the background: breast cancer, we know, is the most common cancer affecting women. 5-year survival is quite good at 87%, and most women in certain populations tend to die of non-breast cancer-related causes. But despite this, breast cancer-related mortality is still the second leading cause of cancer death. In terms of diabetes and breast cancer, of course, diabetes is a very common condition. And we know that women with diabetes have an increased risk of developing breast cancer. It's about a 20 to 25% increased risk. Reasons for this are shared risk factors such as obesity and inactivity, and there's also metabolic factors that are common to diabetes and are associated with an increased risk of cancer, such as insulin and insulin-like growth factors. And there's also sex hormones, estrogens, which tend to be increased in women who have obesity and also lead to this increased risk of cancer. Currently, we know that about 16% of patients with breast cancer currently have diabetes, so it represents a substantial population. And why this matters is because we know that women with diabetes and breast cancer have a higher risk of all-cause mortality. This is an area of great interest, and there are quite a few proposed mechanisms why this is. Women with diabetes tend to present at a later stage of disease, partially due to decreased screening. They may be offered less aggressive treatments, partially due to their comorbidities. They may not be offered all the chemotherapeutic agents. And if they are offered these agents, they do tend to have increased toxicities, which may be driving this increased mortality. And again, there's metabolic effects of insulin and also exogenous insulins from the medications that may also be contributing to this increased risk. In terms of the diabetic medications, we know that insulin and insulin-promoting therapies such as sulfonylureas may increase cancer risk and also worsen cancer prognosis. And the corollary to this, and really the focus of my study and presentation, is the insulin-sensitizing agents that we have, the TZDs, and more importantly, the metformin, and the fact that they may have a protective effect on cancer. What do we know about metformin? It's one of the oldest medications we have currently for treating diabetes. It's the most commonly prescribed medication for diabetes, and is recommended as first-line therapy on most guidelines currently. It's inexpensive, it's very safe, it's well tolerated with a few side effects, mostly gastrointestinal. And the way it works is by reducing insulin and glucose levels via AMPK pathways, which are a cellular pathway. We do have data that metformin inhibits cellular proliferation and increases apoptosis in cancer cells. There's also in vitro data that it reduces colony formation and may reduce tumor growth, as well as acting in an enhancing way with other anti-neoplastic medications. Most recently, there's also been in human studies, human in vivo studies about metformin's effect on proliferation markers. This is a small study of 55 patients who are not diabetic, who were given metformin in a randomized fashion. And they were able to find, and it was only for 2 weeks prior to between biopsy and surgery, and they were able to show significant reduction in a few markers of cellular proliferation, as well as gene expression. In terms of how does it work, the proposed mechanism for metformin affecting cancer growth is twofold. First, through indirect pathways, which is up here, whereby, as I've said, metformin reduces glucose levels as well as insulin levels, and breast cancer cells are thought to express insulin receptors, so a reduction in insulin leads to a reduction in stimulation of the insulin receptor, which downstream from it are multiple lines of cellular proliferation. Directly, metformin also works on AMPK, but directly in the breast cancer cell, and through a similar downstream pathway, which ultimately leads in cellular proliferation, it can downregulate these pathways. In terms of epidemiological studies, there is evidence from 2 large, well-done studies that have looked at the risk of breast cancer in patients who are using metformin, diabetic patients, and it did seem to be associated with a decreased risk of breast cancer, about 20 to 50%, and it really is associated more with long-term use. In terms of prognosis and survival, there's less evidence, but I'll go through these 2 studies quickly. And in terms of prognosis, there was a study that looked at metformin in relation to pathologic complete response, which is essentially these were patients who were given neoadjuvant chemotherapy prior to their surgery, and then they, at the time of surgery, looked at the cancer specimen. And women who are on metformin had a better rate of pathologic complete response, 3-fold, in fact, increased rate, which suggested an increased response of the tumor to the anti-cancer therapies. They extended their analysis to look at survival at 3 years, even though it wasn't their primary outcome, and in this study they did not find a difference. In terms of survival, there's really only one study that has looked at survival. Again, it was a study of women with breast cancer, and only a small subgroup had diabetes. It was an observational study. And with only 63 patients on metformin, and they too were not able to show a significant difference in overall survival at 5 years. But the caveat here is that they used a very select group of breast cancer populations who had triple negative disease, which is one of, first of all, it only occurs in about 15% of breast cancer patients, and it also is a much higher risk, poor prognosis disease. So the limitations of the current studies looking at metformin and breast cancer survival or prognosis are really underpowered, and they've both used a very small sample size of patients with diabetes. In the first study, the outcome really was a surrogate for clinically relevant endpoint. And in the second study, the findings really are not generalizable to the entire breast cancer population. So coming to my research proposal now, the rationale is that women with diabetes, I've shown you, have a worse prognosis and increased mortality following breast cancer. There is evidence that metformin may reduce incidence of breast cancer, and some evidence perhaps that it might improve prognosis. Currently, there's really limited evidence for metformin's effect on survival. The research goal is to evaluate the relationship between metformin use and breast cancer prognosis in a population-based study of older women with breast cancer and diabetes. So the primary objective is to look at among women in Ontario aged 66 or older with diabetes and breast cancer, is exposure to metformin associated with a decrease in all-cause mortality. The secondary objective will be to look in the same population and same exposure metformin, but see if there's any impact on breast cancer specific mortality. The hypothesis is based on the evidence that there will be a reduction in overall mortality and breast cancer related mortality. So the study design is a nested case control. It will be a nested case control study. The base cohort being women 66 or older who have incident diabetes and a diagnosis of breast cancer. And cohort entry will be defined by breast cancer diagnosis. So this is just a scheme of how the cohort will be put together. women over the age of 66 who have a diagnosis of diabetes. And the reason why we're limiting it to incident diabetics after age 66 is we want to account for any exposure to antidiabetics, especially metformin, even prior to their diagnosis, since it's possible that women may be offered metformin when they're so-called pre-diabetic. And I want to have at least a 1 year look back period to assess for this exposure. And then finally, if they develop a breast cancer, then they'll be included in the breast cancer and diabetes cohort. These are the data sources I'll be using. And the outcomes, as I mentioned, the primary outcome is really all-cause mortality, using death certificate information from the OCR and RPDP. And the secondary outcome will be breast cancer-specific mortality. Now this too will be using from the same sources. And here looking for a cause of death, which is breast cancer, so ICD-9 code for breast cancer. Now this is an outcome that has been validated with the OCR, with a validation study done in Mount Sinai. And they abstracted about 1,600 charts of early breast cancer patients and found a fairly high sensitivity and still a specificity of 88%. So it is a good outcome to use. In terms of controls, I remind you it is a nested case control, and we'll be matching cases with up to 5 controls. They'll be matched on age, duration and cohort, and year of cohort entry. This is a study timeline, so accrual will begin in 1994. Once a patient has a diagnosis of diabetes, if we can ensure a 1 year look-back period, we'll follow forward till there is a diagnosis, if there's a diagnosis of breast cancer, and that will make up cohort entry. And then patients will be followed for the index, which is death. So the main exposure is metformin. This will be captured by looking at ODB, the Ontario Drug Database, looking for number of scripts, days supply, and strength. To be called a metformin user, there'll have to be at least 2 consecutive scripts for metformin, with the second script filled within 14 days of the end of the first script to ensure compliance. So this is how I propose to look at my exposure. First will be the category never ever, so any patient who has ever had metformin or is on metformin will be classified as ever, and of course never are patients who haven't been exposed to metformin. The second way I want to look at is to compare metformin users to non-treated users. So in the ODB, this will appear as patients who just have a diagnosis of diabetes but aren't prescribed any medications for diabetes. Clinically, this likely represents a diet-controlled group, but may also I'll leave it at that. And so I'll compare metformin to this group. And then lastly, I'll look at total cumulative exposure. And within this categorization, it will be only metformin users. And we'll look at different durations of exposure. Again, once I get the data, I may have to change a bit the actual years parameters because I do have a relatively long follow-up period, but essentially we're just trying to get at a dose-response relationship. And again, keeping it within a metformin-only user group, it is a way of getting at certain indication bias for why metformin may or may not have been prescribed. So potential confounders, there's always many. And so diabetes duration, socioeconomic status will be something we'll adjust for. Diabetes duration is an important confounder. Of course, the longer patients on diabetes, they may be added other medications, or that it may cause them not to be less likely to be on metformin. This, of course, can affect their overall survival too. Same for diabetes complications. If a patient develops complications, metformin may be stopped. They may have additive therapy because their glucose control is worsening, and this, of course, may also lead to an increased likelihood of mortality. Definitely I'll be adjusting for other medications, other anti-diabetic medications, of which the insulins, the sulfonylurea, and TZDs. Breast cancer treatments is an important covariate. Patients who have, as I mentioned early on, patients who have more advanced disease or more comorbidities may be less likely to be offered aggressive treatments. And of course, this could lead to their increased mortality. It's important to account for it. These medications, beta blockers, statins, bisphosphonates, SSRIs, and the non-steroidals, have recently been associated with with breast cancer mortality specifically and breast cancer recurrence, so it's important to account for them. Steroids often may denote progression of the breast cancer, and with steroids we know glycemic control is worsened, so patients who are on steroids may be less likely to be on metformin and may have increased sort of mortality as well, which could definitely bias the results if we don't account for it. And then looking at specific comorbidities, which again can very much affect overall survival, and then the Charlson score. In terms of the analysis, it'll be a conditional logistic regression using both the univariate and multivariable models. In the final model, we'll include covariates that are significant on univariate analysis, or the ones that significantly affect the OR rate ratio using the 10% rule and looking at the overall model. And then lastly, but very importantly, potential interactions. So I haven't said anything about stage yet, and I've kept it to here. We're going to be defining stage, but we won't adjust for it. Look for potential interactions by looking for interactions in the model, and also and we have suspicion to think that it could be also an effect modifier. So the next slide I'll talk about how we'll stratify for it as well. But stage essentially will be defined by whether or not a patient has had surgery within 1 year around the diagnosis, because we know that patients who present with late-stage disease, which is stage 4, are not usually offered surgery. They're offered systemic therapies. And also looking for interactions with tamoxifen and aromatase inhibitors. These are medications that are given to women who have hormone receptor positive disease, which tends to be a better prognostic category of disease, so we want to see if there's any interaction between metformin and these agents. As I said, I'll be stratifying for early versus late stage disease. I'll look for interaction, but despite that, because I think it's such a strong confounder, I'm going to account for it by stratifying, and then hormone therapy if there's positive interaction. And then I'll be doing subgroup analysis also, again, to try to tease out the effects of the different anti-diabetic medications. So we'll exclude insulin users to see if our effect with metformin still holds. And also attempt to do a subgroup analysis looking just at metformin exposure after breast cancer diagnosis and see if that has, because initially my primary analysis is going to be looking at total exposure, which could occur prior to breast cancer. And then in terms of the power calculation, these are the basic 2 assumptions up top. And based on my knowledge of the incidence of diabetes in Ontario and the incidence of breast cancer, I estimated that I would have about 5,000 patients in my cohort, and estimating very conservatively, I think about a 10% mortality is probably more. These are the sort of expected odds ratios and the power for looking at overall mortality. So finally getting to the end of the presentation, the strengths of this study is that I'll be using a large population-based database with the universal provider, so I'll really be able to look at all comers with breast cancer. I should have enough power to detect an influence on metformin on overall survival. The databases specifically that I'm using are validated databases, and the OCR, the ODB, and the ODD. And also I'll have a large incident diabetes cohort, which is something that really hasn't been looked at in most studies, and probably due mostly to power issues, because we know that having an incident diabetes cohort really helps minimize some of the indication bias especially. My limitations, of course there are limitations unfortunately. First of all, the outcome is based on death certificates, but as I've shown you, there was a validation studies even for a specific risk of death, and it is still a good outcome to use. The power for breast cancer specific mortality, I may not have enough, just given the fact that women, especially with early stage disease, are much more likely to die of other causes rather than breast cancer mortality, so my cases might be low. Stage data is lacking, as I've already mentioned, and one major, and I think a good way to account for this is to stratify based on early stage, which is stage 1 to 3, versus late stage, which is stage 4. So there is despite using the inception cohort or the incident diabetic cohort, there still is a risk of indication bias in the sense that patients who are on metformin may be healthier. And so, of course, there's a risk of the healthy user effect, so they may look like they have better outcomes. The generalizability, so I am looking at women only over age 66. So generalizability to younger women or women who's had much more long-standing diabetes. But the good news is that about 50% of women who do develop breast cancer are in this age group, so I will be addressing a problem that's applicable for a large part of the breast cancer population. Of course, there are unmeasurable and unknown confounders, and most importantly BMI, but I can adjust for other covariates instead, I guess. And finally, the difficulty in disentangling the harmful effects of insulin and sulfonylurea versus the protective effects of metformin is a major issue. Ways I'm attempting to address that is the untreated comparison group, as well as the subgroup analyses where I remove insulin users to see if I still maintain an effect. And finally, the implications. So it will be the first study to really describe a role of metformin on survival following breast cancer. I think it will, because I'm attempting to explore the exposure to metformin at different stages around breast cancer diagnosis, I think it can inform both endocrinologists like myself as well as oncologists, seeing if metformin added at different stages makes a difference or not. And overall, even though it's a widely popular area of research right now, it's still not so well understood, so I think it'll just lead to a better understanding of the link between breast cancer, diabetes, and these agents. So thank you to my committee members and my advisors.
That's great. And Iliana, that's also exactly on time. Congratulations on that. Okay, so 10 minutes for questioning. Peter, you're first.
So I have two questions, one of which is very brief. So in your introduction, you mentioned that metformin has been known since the Middle Ages. So
Yeah.
they obviously weren't using it to treat diabetes. I'm just curious as to what it was used for.
As far as I know, it probably was used to treat diabetes. It was used to treat polyuria. And polyuria is a symptom of uncontrolled diabetes.
So secondly, so in your design phase, I think you talked about removing patients who had diagnoses of other forms of breast cancer, either prior to or after the breast
Other
cancer.
cancers, right.
And so you have this base cohort where you have women who had diabetes and then who developed breast cancer, and that becomes the cohort that treated the breast cancer base. And
Yes.
you remove women who then either prior to that or subsequent to that develop other forms of other cancers. What are some of the implications of if a woman enters your cohort with breast cancer and then subsequent to that develops lung cancer, say, what are the implications of removing her from your cohort after the cohort entry date?
Well, part of the problem is that metformin may have, I guess I just wanted to keep my cohort clean and to really be a diabetes with breast cancer population. The problem is metformin may also have an effect on her other cancers. And it would, I guess the risk estimate for the mortality really would just be much messier because it would have more to do probably with the lung cancer than anything with the breast cancer or diabetes.
But the women who develop a secondary cancer, do you think that they are, on average, different from the women who don't subsequently develop a second cancer?
That's a good point. And clinically speaking, it is possible because they may have other risk factors which have led to this. For instance, lung cancer, they may be smokers, so they may be overall have worse problems.
I don't know the answer, but I wonder if there's a danger to removing to systematically removing people who post-cohort entry are the sicker
I see.
people.
Yeah, that's a good point.
Craig, is that your point?
No, it's a different question, if that's okay. Very nice. I'm trying to think through the possible effect of the stratification on stage that you're doing, because you're defining your exposure from the start of diabetes. This is really more about if you're diabetic and you're on metformin, does the breast cancer you get, is it a worse breast cancer, or is it a better breast cancer, or a more deadly breast cancer, as opposed to asking the question, once you get breast cancer, should we start giving everyone metformin as part of their treatment or an adjuvant to their treatment? So in the latter one, I think it is clear you'd want to be stratifying and taking stage very much into account. But are there potentially negative effects to doing that if it's that first question about, are you biologically getting a different breast cancer because you were on metformin?
So that's definitely something I've thought about, and the literature would just make you think. Unfortunately, we don't know, so currently there isn't any evidence, and that's definitely one of my future projects that I'd like to do, especially with the stage data now, looking at metformin in stage and if it may have an effect. But because we don't know, I decided to just leave it all as sort of one big hole, but I think it's definitely something to think about. I mean, that was one reason why I was trying, in the subgroup, I wanted to tease out just if metformin is started after the breast cancer diagnosis, how that affects, because of my thinking that perhaps having metformin prior to the diagnosis really affects the tumor biology and what it ultimately
Okay, Rick?
I may have missed it. Could you explain who the controls are, what disease they have or don't have, and how they'll be selected, and whether there's any matching on any variable?
Sure. So I guess it depends on which. I propose to look at metformin in a few different ways, but for instance, in the never-ever group, in the never-ever group, the ever users of metformin will be, and first of all, it's a nested case control, so we'll be looking back for an exposure to either metformin or to never metformin. But within that never metformin group are the other anti-diabetic medications. And I will attempt to look at them all individually too in the model, but they essentially could be insulin users, sulfonylurea users, combination of all those users. And so I'll be comparing, I'll be comparing those to patients who were exposed to metformin. And the matching of the cases and controls, so cases who die, will be based on age, cohort duration, and at calendar year. And those are calendar years to try to account for differences in breast cancer treatments, because it's a fairly long follow-up period of 14 years. And then cohort duration, just to make sure they have the same risk in having been in the cohort that long.
So you're going to match on those variables. How are you going to pick the 5 controls for each case?
My understanding was that it's just like sort of how will they be matched. So I guess they're matched on those, and if we have, are you getting at whether or not if I have more, will I use more controls? Or?
Yes, if you have too few or if you have too many, how will you handle that?
Right, so having too few controls could be a big problem. And at that point, I guess I would have to either consider changing the design if I had too few controls, or limiting to age, because one of the concerns could be, for instance, in patients, I'm not limiting my cohort to an age cutoff, so obviously women who are in their 80s, it might be quite hard to find 5 controls who are alive. So perhaps limiting the age of my cohort would be a way to deal with that.
And what if there are 100 controls and you're just looking for 5?
So my understanding, there have been some studies that have compared numbers of control 5, 10, 20, 40, and it doesn't give you much benefit in terms of your estimates. And that's my understanding if you go up much further than 5, so that's why I sort of limited it to 5. But
So you would just choose a random?
it's not so much random, I guess.
How would you pick out of 100
Sorry.
to get your 5?
I see. That's my understanding.
All right, Julie, did you have a question or? Well, for me, I don't see any intention present. How much did you struggle with how to define time 0 as the date of the diagnosis of diabetes, or the date of the diagnosis of
For
breast
the
cancer,
exposure?
or something else? And having them work through that struggle, any thoughts of using a proportional hazards analysis rather than a logistic regression analysis for the primary endpoints?
So for the first question, I guess I thought it made most sense to me to use ever exposure to metformin, which is essentially why I chose the inception cohort, because I wanted very much to be able to see how much exposure they'd ever had to metformin. In terms of the second question, you're not getting at the issue of just the design of the, because I know there's a lot of questions about why a nested case control design, and which is where you most commonly use a logistic regression model. Is that what you're sort of asking? Why did I not choose cohort, or just
if you've got a clear time zero and you're tracing these individuals forward through time, the proportional hazards would be a little bit more statistical power, right? Because obviously, if a woman dies of breast cancer, proximal, then it's maybe an indicator of more aggressive disease than
Part of the problem is going to be modeling the time-bearing exposure, because metformin and the other antidiabetic medications too. And my understanding is that that's quite complex to do, but not just to sort of use the easy answer out, but nested case control is a really nice way to take into account the time-bearing nature. So it's sort of a good alternative.
Jan?
Nice presentation. The indications for metformin have sort of risen and fallen over the last decade and risen again in the context of one of its chief competitors, rosiglitazone. And so people who, in the heyday of rosiglitazone, were getting metformin would be quite different than people prior to rosiglitazone or contemporary users. How will you account for that in your analysis?
So are you suggesting that patients who would not have been getting metformin before it was considered first line would have been patients who, because metformin has always been covered, I guess.
It's always been first line, but I think there was tremendous creep in practice toward the use of TZDs once they came on the market, and so that less and less people would have been getting metformin.
Right. No, exactly. I guess I just haven't really thought through of how those patients would be different specifically from metformin in terms of their biology necessarily, because they'd still be early diabetics who are relatively well controlled, but I haven't thought more about how they would differ really in terms of, if you're getting more at socioeconomic factors, or
could be, or evidence-based prescribing by their caregiver who is following guidelines and also getting them on an ACE inhibitor.
I see an overall better, so okay. That's very interesting.
But you did say you were going to control for calendar year in your model,
Yes.
so that will get at.
Okay.
All right, I don't see any more hands, and we are at the 9-minute mark, so we will get you off slightly early. We're done. Thanks very much.